It's nice to know a bit about who I'm talking to and what level you're at, because actually I go into quite a lot of detail in this talk. I'll talk about everything. I think some of it can feel a bit overwhelming right at the start. If it gets too much, I'm not going to be offended if you disappear, or if you need to stop me and ask some questions, that's completely fine, okay? So I always put this slide up at the start because, you know, when we think about rare conditions, PTEN affects so few people. And so one of the things that's hard for families is trying to find other people who it affects, but also for doctors and researchers, trying to gather enough information to know what is the right advice to give, and knowing that we are giving good advice that's based on good evidence. And some of it's based on experience, and what we try to do more and more is collaborate around the UK and around Europe and around the world, so that the more people that you get evidence from, the better the advice we're going to give. Okay, but collectively these are not rare. There's lots of rare conditions, and I think trying to raise the profile of rare conditions as a group is really important as well. Okay, so I think what is really confusing for lots of people when they get this diagnosis is why on earth are there so many names associated with it? There's one gene, but when you look it up, there's all sorts of different conditions. So I'm going to address that a bit, and it's a bit of a history lesson about the condition itself. So before the gene was described, there were lots of case reports. So doctors like me see children in their clinics, see adults in their clinics, and we're referred people who have a collection of medical problems or developmental problems, and we're trying to work out, well, why? Why has this person got this constellation of issues going on? And can we put them together in a pattern? And syndrome just means a pattern. Can we recognise that pattern to make a diagnosis? And if we can recognise that pattern, do we know what gene to test to try and prove it? Because that might help us to give better advice. And in the long run, if we understand that gene better, it might help us to give better treatment as well. Okay, so this name, Banyan-Ruvalcaba syndrome, you might see BRR written, linked with PTEN, okay? And that's a condition, it's the names of 3 doctors who described families with a mixture of these issues going on. And so the condition was amalgamated together by Professor Gawlin in 1989 to be called Banyan-Ruvalcaba syndrome. And this was before the gene was known. And the children and the families they were describing were people who had macrocephaly, which just means big heads. And that's often the most obvious thing. And if you go and see a geneticist like me, I get really obsessed about, is this person big, small, big head, small head, proportionate, disproportionate? And all those things help my thinking to go, okay, well, it's none of those things because they would have a small head if they had this. And it's none of those things because they'd have a normal-sized head if it was that. So it's this group I'm looking at. And then we're thinking about other clues. And those clues, and often the reason that children get diagnosed is because there's an issue with their development. So they might have some developmental delay. And for children with a PTEN diagnosis, often that is that they're being a bit slow reaching their motor milestones. So they may be a little bit floppy, or the doctors would call it hypotonia, and maybe not rolling and sitting as soon as possible. But lots of children with this condition, most of them, make good progress in the longer term. In my experience with this condition, they do learn to walk, they do learn to do all these things, it just takes them longer. But if you think about the mechanics of it, they've got a big head on a little body. And what seems to happen is that as they grow bigger, they then are able to accommodate that better and get some more strength in their bodies, and they do seem to make good progress in the long run. But those first couple of years, they can seem quite a long way behind. There's lots of nodding going on over here. So other things we might see, so there may be some other developmental issues, maybe a bit of delay with speech and so on. Lumps and bumps on the skin are quite common. And if you have a child with a big head developmental delay and a lipoma, you're going to test the PTEN gene, or I would. But you know, you've got to get to see someone who, like me or Mark, who knows about it, and that can sometimes be the journey that people have gone on to get that diagnosis. Lipomas are just soft, fatty, filled lumps. They're harmless, but they can be uncomfortable, or they can be in a place that you think, oh, other people are going to see it and doesn't look very nice. Other things we see that can be clues in boys and men, although it's not necessarily something that they share, but they can have freckling over their penis, which is an unusual finding, but it can be a clue. Other things we see are lumps and bumps in the bowel. So some children present with diarrhea and gut problems. And when the doctors look inside their bowel, usually what they see is a very lumpy surface. I think there's a picture later on in the talk. But when it's biopsied, we don't actually see very much. The histology comes back, and it's not very exciting histology, and it's sometimes described as a hamartoma, which is just describing the appearance down the microscope. But we get all sorts of different reports of what that is, but it's benign in children. It's not a cancer. And then the other things we sometimes see if it's inherited through the family are thyroid disease, and I'll talk a bit more about that later on. Okay, so Cowden disease is the other condition that people might hear about. It's still written about. People still use this term in the medical literature when they're describing patients. It's an unusual condition because it's named after the patient. Most syndromes are named after the doctors that describe them. But Rachel Cowden was a young woman. She had some intellectual disability, but it's not very well described in the original report what that means or how it particularly affected her. She was diagnosed through dermatology, and they recognised these unusual lesions that she had over her face and her mouth. She also had lumps in her thyroid. And she was also described to have very lumpy breasts, which is fibrocystic disease. And she actually went on and died of breast cancer at 31. This is a long time ago. And I think we're much better at detecting things and treating things much earlier now. So there were more reports that came out, and lots of those reports came through adult dermatologists. So the early reports of the children are coming through paediatrics, and then later on through clinical geneticists. And then these reports of people of Cowden syndrome are coming through dermatology services, and then a bit later on starting to emerge through adult doctors who treat cancer. And so all these different names appear because it's different groups of doctors that are describing them in different medical journals. And not just one group. And it takes a while before those groups of doctors who work in very different fields start to see that there are other groups of doctors seeing the same group of patients, and that actually perhaps these patients all have the same condition. So, does that make sense? Yeah? So these are all the different names that have been associated with alterations in the PTEN gene. So I've talked about Banyan, Riley, Ruvalcaba syndrome. There's sometimes a Zanana name gets put in there as well. Cowden syndrome. Lermite-Duclos describes a condition that happens in adults that is a growth in the back part of the brain called the cerebellum. And it's a very slow growing tumour that can grow in the back part of the brain. It's benign, but it causes problems because of where it is, because it happens in the enclosed box of our skull and causes increased pressure. And so when we talk to patients, what we want to know is, are they getting new symptoms, new signs, and we take that very seriously. There's one report of a child with an alteration in the PTEN gene who had a really big head and lots of other congenital abnormalities that fit into this diagnosis called VARTA. Benign familial macrocephaly is a description of people who just have a big head but no other problems associated with it. And actually they sometimes get investigated because perhaps labour's been very difficult because a baby's had a very big head. And then the doctors keep an eye on that baby because their head's so big and notice it's getting bigger, and they get a brain scan and the spaces inside the brain, the ventricles, look a little bit big. And then we notice that somebody else in the family, mum or dad, has the same thing, but they've often not had a lot of other problems. Other people, I think my next slide talks a bit more about autism, so I will leave that one. Proteus is another condition where there is overgrowth of parts of the body. There are people with a PTEN gene alteration who have this condition called Proteus as well. It's something that is apparent from quite early on, that a bit of the body is overgrowing. It's not something that tends to occur later on. And I always think that's important to point out when I'm talking about this. We would know about it if someone had it. Okay. And then the gene was described. So in the mid to late 90s, there started to be different reports finding this gene. I haven't put slides in about genes and what they are and inheritance patterns. I have got them right at the end. So if anyone wants me to do that bit, I can do it. But perhaps I'll leave that bit till the end if anyone wants a bit more information about it. I sort of assumed that to get here, people have had that sort of information given to them already. Okay. So just a little bit about inheritance patterns. So lots of people with a PTEN gene alteration, it's happened for the first time in them, it's not inherited. And I always think that must seem like an unusual thing to be told, that actually a genetic condition can happen for the first time in somebody. It doesn't have to be inherited just because it's genetic. Everything has to start somewhere, and our genes have to copy themselves to make an embryo or to carry on copying our cells as we grow. And it's not a perfect process. So what happens once we know someone has this condition, what's the chance of them passing it on? And it's 50-50 chance of passing it on. And it doesn't matter if that child that's born is male or female, the chance of them inheriting it is the same each time. What we don't understand well, and what some of you might observe in your families or in other families that you get to know, is that some people are really differently affected from other people in the family, and that people with the exact same change in the gene can be quite differently affected from people in other families with the exact same change in the gene. And they all have issues within the same spectrum, but not everybody gets everything, and in fact most people don't get everything. If you look at a family, there'll be someone with developmental issues, someone who's grown up and had problems with tumours, somebody else who the biggest issue has been a big head, someone else who's had lumps and bumps, and you get the occasional person who gets a lot of these issues. Or we start to find lots of those issues because we've made the diagnosis and we go looking for them. Okay, that's just another slide explaining autosomal dominant inheritance. So we all have 2 copies of every single gene, and when you pass those on, there's a 50-50 chance of which one you pass on. So if you've got one altered copy of the PTEN gene, you can pass this on and you'll have a child that's inherited it from you. And this parent is always going to pass on an unaffected copy. And because it's such a rare condition, the chances of your partner happening to have it too, unless I suppose you met them here, then are pretty small. Okay, I think I've already said all of that. Okay, some little bits further down here. So we can't predict severity. It is possible to offer prenatal diagnosis, and that's starting to change a bit. So we'd always been able to offer testing if people wanted it, and it's something that is talked through with a genetic counsellor at great length generally. Everybody feels very differently about it. But that's something that can be done by putting a needle into the womb and doing amniocentesis or chorionic villus sampling. There is a new technique called non-invasive prenatal diagnosis, where if the father is the person who has the altered gene, you could look for the gene alteration in a blood test from mum, rather than her having to have an invasive test in the pregnancy. So that's a very new thing that's just starting to become available. Pre-implantation genetic diagnosis is an IVF type procedure, and it is possible to get funding for it on the NHS, but again, it's a very personal decision about whether that's the route that people want to take. Okay. Right, making the diagnosis in children. I've done quite a lot of this already, actually. So if we see somebody in clinic, what's going to make us think about this diagnosis? So a big head really will. Lots of children who are referred to our clinics have autism or developmental delay. That's what's prompted the referral. So a lot of the children we see, that's why they've come to see us, because their parents are really worried about their development. If they only have a big head, they may never get referred to us, because the paediatricians are sorting that out and there's not other things running along with it. It tends to be when there's more than that going on. Other things we look for are the skin features. So I've talked about lipomas and some of the other things we see. And then the other thing we recognise more and more is vascular malformations. So where there may be a lump or a bump that's got some bluish discoloration, and is usually very soft. And those can be quite problematic because they can grow through the tissues, but those can be another clue towards the underlying diagnosis. And then the other thing that sometimes happens is polyps in children. So those are not cancerous polyps. I'll talk a bit more about cancer later on. But they can secrete fluid, which can cause diarrhea. And in very little children, if they've got a polyp in their bowel, it's quite important to know about it because the bowel can constrict around it and cause a surgical problem. So it's important to be aware of those if you have this diagnosis. Okay, so head circumferences. This is a chart from my research from a long time ago now, but I still like it because I think it shows you how big people's heads are with this condition. So if you remember your red book, if you've got children, and the doctors like to plot children's weight along here and on the growth charts, this is the one for heads. And we'd expect about 50% of people's head to be around this line, and then the rest of them are scattered around this graph. But out of 100 people, we'd expect all of them to have head circumferences between here and here, and then maybe 1 out of 100 or 1 out of 1,000 to have them beyond these lines here. And if you've got a PTEN gene alteration, your head is always along here. These are the adults. We don't have adult head circumference charts, but you can see how big people's heads are, actually off the top, if you plot them using the same scale. And the difference here is proband means the person who was originally diagnosed in the family, so the first person to get diagnosed. And so what you would think is that they would have really big heads because that's what prompted the doctor to do the test in the first place. But actually, if you look at the blue crosses, which tend to be their parents, they do have really big heads as well. And the same for the women as well. Okay, how am I doing? Learning difficulties in autism. So, if you take a group of children with autism, so autism is a descriptive term, it describes children with certain behaviours, and it's a very variable spectrum. So there are some people who are perhaps an extreme of, I don't like using normal, but there isn't a better word, who may be an extreme of normal behaviour. So they like things being done in a very particular way, they don't like their routine being upset, they perhaps find it more difficult than other people to interact and feel difficult in social situations. Then there is a spectrum towards people who don't learn to talk and don't interact, don't make eye contact, and have perhaps quite ritualistic behaviours. If you take a group of children with quite classical, severe autism, about 10% of those children with autism and a big head have a PTEN gene alteration. So for most children with autism, we don't find the cause. But if we measure their head, we should be thinking about testing this gene if it's big. And then when you look at these studies, the head circumferences in those children who were found to have a PTEN gene alteration, they're not just big, they are the really big head circumferences. So they're the ones that are right at the top of the chart or above it. But not always. And so if you're thinking about trying to get a good pickup from a test, you're going to test children whose head circumference is probably above the 98th centile or thereabouts and above it. Okay. Some of them have inherited the gene change from a parent, but the parent doesn't have autism. We've talked about genetic and not inherited. And about 10 to 20% of people with a gene change have some learning difficulties. And what I found interesting when I did my project travelling around the country was that there were a lot of people, the adults, whose child had been diagnosed, who described that they had had developmental issues as children. They'd been a bit slower to walk, perhaps a bit slower to talk than other people. But the majority of them had done really well through their lives. And actually, as a group, the group that I saw academically had done really well, and a lot of them had been to college and to university. What's difficult with a study like that is what motivates people to take part. So were those people more motivated to take part because they were more educated and more likely to access a study or services? And that bias is impossible to take out. Right. Diagnosis in adults. So if you're not diagnosed as a child, what happens to lead to a diagnosis in an adult? And it can be lots of different things. And again, it's this idea of pattern recognition. So if you're referred to a geneticist, they will look at the pattern of issues that have happened in that individual, but also through looking at the family history, taking the family tree down and trying to recognise a pattern. And the patterns we see are problems in the thyroid, and all the things you can see here. I'm going to talk through them all with some more slides. Okay. What do we need to know first? Because I think it's really important to try and understand this properly. So the medical language that doctors use can sound a bit scary, I think. And it's important to understand what we're talking about so that you understand it properly. So when we talk about cancer risks, we talk about tumours, and we might talk about benign and malignant tumours. So a benign tumour is a growth, It's a lump or a bump somewhere where there shouldn't be a lump or a bump, but it's not cells that are growing out of control. And it's when cells are growing out of control and causing a problem that we can't control that they get called malignant and a cancer. Benign problems are lumps and bumps that are a nuisance, they're unsightly, you might be embarrassed by them, they might be painful, and that might just be because of where they are. So if they happen where your bra strap rubs or where your shoelaces tie up, something like that, they can be really annoying. And malignant growth is one that is a cancer. It can start really slowly to start with, and it can be really difficult to know at the start about that and which it is. But the good thing about the surveillance is that we try and find them early on, so that they don't get to that stage while they are growing out of control with the possibility of spreading. Okay. So what are the sort of questions? What are the chances of it happening? Will screening or surveillance help? Can we pick it up early with screening? Is there any good evidence that doing the screening is the right thing to do? If you're going to take time off work and travel to a hospital, you want to know it's a worthwhile thing to do. Are there other options? And what's the downside of it as well? Okay. I'm going to move on to the next one. Okay, there's lots of words on some of these slides, so I'm not going to talk through all of them. What's the thyroid gland? Lots of people haven't heard of it before they get this diagnosis. They might have done, but it's a gland in your neck. And a gland is an organ that produces hormones, and those hormones are really important to make us have enough energy and to keep us fit and healthy. In people with a PTEN gene diagnosis, lumps and bumps in the thyroid are really common as people get through to adulthood. So at least 75% of people, once they're adults, will have lumps and bumps in the thyroid. And then if we go looking for lumps and bumps, how do we know which lumps are just a lump that doesn't really matter and which is a lump that might be a cancer or turn into a cancer? And that's the challenge of screening in this condition. And so what we try and balance is when is the right time to start, so that we're not making people more anxious by finding lumps and bumps that are very unlikely to be a cancer. And when's the right time to start doing it more often, because people are reaching an age where that's more likely to happen. And what do we do when we find a lump? So the things that might happen are that the doctors might do a biopsy of it. They might put a needle in it to take some fluid from it, and that gets sent away and looked at under the microscope, and that can help with diagnosis. Okay, breast cancer risk. So this is, for women, the most commonly associated malignancy. And when I talk to parents of little girls, this is something they get really anxious about. And actually, little girls don't get breast cancer. They don't have breasts. So this is something that happens and is something to be concerned about as women get older. And the chance of getting a breast cancer starts from around the age of 30. So before that, we don't do any screening. The older reports in the literature say the chance of a breast cancer is between 25 and 50%. The more recent reports from the sort of 2010 onwards suggest the chances are higher. And if you looked on the slide about thyroid cancer, you'll have seen the same thing. The chances look higher in the more recent papers. Now, those papers say what happens when a doctor writes a paper. They gather together a group of patients, all with the same condition, and say what's happened to them and what age did it happen to them. And then they say, okay, well, 80% of people this happened to. That sounds very high, and of course it's important. But what you have to do when you read something like that is think, okay, but what about the group that they looked at? Did they look at a representative group of people? And what happens with these studies is that the people who are being studied have been diagnosed because they had a cancer. And if they hadn't had a cancer, they wouldn't have been in the study. So actually what we need to do, and that's why the registries going forward are so important, is to try and look at the people who were diagnosed younger or because of another family member, or were diagnosed with cancer but then go on and get a different one later on. And what we want to see is that natural history. What actually is the chance of it happening? Because these figures probably overestimate it, and probably it's somewhere in between these figures. It might be lower, because even these people will have been diagnosed because they got a cancer. And we know that not everybody with a PTEN gene alteration does get one. So we probably are overestimating it. But we still need to do the best we can to screen and treat people and take those seriously. Okay, endometrium. So again, you know, they're all words you might know, but you might not. The endometrium's the lining of the womb. Again, the chances of this, the papers that came out around 2012 give a slightly higher chance. The earlier papers give a slightly lower chance. The screening for endometrial cancer in the UK and other countries is quite different. So in the UK, the studies that we've looked at that take a little bit of a biopsy from the womb, what we're concerned about is that you're just taking a tiny bit, you're not looking at all of it, and it changes every month with a monthly cycle. So that doesn't seem to be an excellent way of screening for endometrial cancer. And so in the UK, the discussion tends to be, because this is a later risk, that when women have finished their families, they might think about having a hysterectomy. So that's having the womb removed, because that takes away that chance. Okay. Renal cell carcinoma. So renal means kidney. It's cells in the kidney. The chances here, again, are lower. We did an audit looking, in 2014, 15, time goes by, I think it was 15, of UK patients with this diagnosis. So we got in touch with all the clinical geneticists in the UK and asked them to try and pull out the notes of their patients with a PTEN diagnosis. And actually, this was something that wasn't being screened for. And we found a small percentage, so similar numbers to this, that actually when they had screening, it was picking it up. So that's been introduced into the guidelines, and that's done by either an ultrasound scan or an MRI scan. But again, it's something for later on. So if your children have been diagnosed, this is something we think about from the age of 40. Okay, this is the picture I was telling you about. So this is the inside of the bowel, and you can see how lumpy it looks. It should look a bit smoother than that. And these lumps are not necessarily anything to worry about, but they do look quite unusual to the doctor doing the colonoscopy. So if you look at people with a PTEN diagnosis and do a colonoscopy, which is where you put, I always think saying you put a little camera inside to look in the bowel. Well, what on earth does that mean if you've never seen what it is? So it's like a little flexible tool that they put inside your bottom and put up through your bowel to have a look at the inside of it. And lots of people have polyps when that's done. But those don't seem to be cancerous polyps for the majority. The chance seems to be a little bit higher than in the rest of the population, but it's not a hugely increased chance. But that is in the screening guidelines. Again, at 35, and if there's no polyps, not to do it again until 50, and if there are, to do it as seems appropriate to the doctors who have done the test itself. Okay, so what are the key things? So the chances of a cancer in childhood are really low. We can't say they're nothing, but they are really low. And we would monitor children, we take any symptoms very seriously that parents are worried about. But there isn't a lot of screening that needs to happen in childhood. And what about screening tests? You know, do we know they're going to do any good, and what's the downside of them? So you have to go to hospital, you have to park your car, you have to go on the bus, and maybe it doesn't run very often. There's all sorts of reasons it's hard to do these things. It's stressful, it's time off work, it's time off school, and it has to be a balance between what's a helpful thing to do and important, and trying to get the timing right and not to make it impact on people's lives too much. Does it actually work? And are we going to pick up things that actually don't matter and really feed back into this stress and anxiety because we're finding something and we're not sure what it is or what to do about it? And how often should we do it? And I think what we come back to is that we have screening guidance in the UK now. So all the evidence was looked at by the UK Cancer Genetics Group, and last year the guidance was updated, and so these are the current guidelines. I've lost my train of thought completely. So this is what we recommend at the moment. If you look at the thyroid, and this is a thing that I think for a lot of people seems to be the more difficult thing to decide what to do. So there are reports of thyroid cancer in children, but they are few and far between. And what we do is talk to families about the best time to start. And for a lot of people, they say, okay, let's just be aware of symptoms, we'll start at 16. Other families say, actually, I'd rather start a bit before that and just get used to going for the screening. And I just feel a bit uncomfortable about this. Let's start it as we start to talk to children about it. And we will do it from younger if there is a family history to suggest that that's important in that family. Or after quite a lot of informed discussion with the family and actually trying to make sure we can get access to it, that someone will do that for someone who's younger. Okay. So I haven't put a lot about the audit in here. So this audit, it was all anonymous, and we collected information from all the UK clinical geneticists about their patients. And there were 175 people included in the study, and these were all adults, so this did not include any of the children who are affected. So we think we were a little bit surprised, I think, by the number of people that were affected when we collected the numbers together. And we looked back to see what screening advice had been given, and it was completely anonymous. So I looked at the data, but I had no idea who it had come from or where it had come from. Okay. And that helped us to inform our guidance, and the plan is to go back probably in 2020 to go back and do that again and see are people getting the screening, and if they are getting it, what has it picked up, how useful has it been, so that we can revisit that and refine the guidelines if necessary. Okay. For some people, and I hear this, so you're growing up, how do you get back into the system to get your screening? Or what if it's not happening? How do you get it to happen? And I think you can go back to a clinical geneticist. I think for the most part, we are the people who are giving advice about how often it should happen. Some centres coordinate it themselves. For a lot of centres, they give the advice and it's coordinated by the GP, with the person themselves taking on the lead and saying, okay, I need to go back and say, I haven't had this scan this year, can you order it for me? And it's a sort of, you have to work out the best way to do it for each individual person, where they are in the country, how close their hospital is. So trying to make it all the same for everybody isn't really possible. If you live in a big city, it's probably going to be done a bit differently to if you live way out in the countryside. But it's that making sure everybody, and I think it's really important that patients and their families know what the guidance is and know who to go to try and help to get that to happen. And there's a link here that tells you how to get in touch with your local clinical genetics services. Lots of services, you have to go to your GP to get a referral. I think there are some services, Southampton's one of them at the moment, where if you've been seen before, you can ring up and ask for a review appointment, which seems sensible to me if you've got a genetic diagnosis. It's not gone away. Okay.